Stroke is the fourth leading cause of deaths and disability globally, and the primary cause of mortality in developed countries. That is not the case now, as low and middle-income countries account for 87% of total stroke deaths worldwide, and the number of disability-adjusted life years in these countries is 7 times higher than high-income countries. Unfortunately, in India alone, it is predicted that around 6.36 million disability-adjusted lifetime is lost due to strokes. Atrial fibrillation is the leading cause of cardiac ischemia and stroke in India, affecting patients from the age of 45 years and above, which is 10 years earlier than patients in Western countries. Atrial fibrillation is also a significant contributor to mortality, cognitive decline, and stroke in patients, with an exponential increase in healthcare costs affecting diverse populations. Non-valvular atrial fibrillation makes up approximately 70% of the total atrial fibrillation patients. Non-valvular atrial fibrillation is defined as cardiac rhythm disturbances restricted to cases in which the rhythm disturbance occurs in the absence of rheumatic mitral valve disease, a prosthetic heart valve, or mitral valve repair. Non-valvular atrial fibrillation has also been associated with a 5-fold increased risk of stroke, with stroke being more fatal and disabling than in those without atrial fibrillation. Estimate of incidences illustrate the significant burden of NVAF, as mortality remains particularly high around the time of diagnosis. Case fatality increases with age, being systematically higher in men than women. Warfarin used to be the anticoagulant of choice, but the obstacles of effective treatment was compounded by the substantial numbers of patients in Asia who are not treated with OACs, usually vitamin K antagonists, that is, VKAs. Example, warfarin. Even in the patients who manage to obtain warfarin therapy, the effectiveness is often compromised due to poor quality anticoagulation control, as reflected by poor time in therapeutic range, that is, TTR, or not having access to a structured anticoagulation monitoring service. In an Indian study, INR monitoring was seen to be irregular in 25% of the Indian patients with atrial fibrillation, which can have detrimental effects over the patient's condition on warfarin. A meta-analysis revealed that 44% of bleeding complications with warfarin has been associated with supratherapeutic international normalized ratios, that is, INRs, and that 48% of thromboembolic events occurred in patients who had subtherapeutic INR readings. INR monitoring is an integral part of the warfarin regimen and is recommended once in every 4 weeks for patients on stable warfarin therapy. Due to the narrow therapeutic window of warfarin and variation in individual responses, maintaining in-range INR becomes a challenging task. In addition to the INR monitoring issue, a patient on warfarin is advised to keep the dietary intake of vitamin K as less as possible. However, traditional dietary practice of Indian patients comprise of a plethora of green leafy vegetables, a rich source of vitamin K. Upon dietary intake, the efficacy of the warfarin dose administered is comparatively reduced, as the excessive vitamin K potentiates significant change in INR. Fluctuations in the INR can increase the chances of bleeding disorders in the patient. Furthermore, common OTC medications such as NSAIDs, and common antibiotics are known to interact with warfarin. This makes it more difficult for patients who require certain medications, especially elderly and immunocompromised patients. Dabigatran is a novel oral anticoagulant, FDA and EMA approved, and NICE, ESC, AHA, HRS, and ACC recommended therapy for prevention of stroke in non-valvular atrial fibrillation. Dabigatran is a potent, reversible direct inhibitor of thrombin, which is responsible for converting fibrinogen to fibrin in the coagulation cascade. Dabigatran also inhibits the effect of thrombin-mediated platelet aggregation. Dabigatran has a unique mechanism of action. It has the capability of binding and inhibiting both free and clot-bound thrombin, thereby preventing thrombus formation. Direct inhibition leads to an effective anticoagulation effect, which is why Dabigatran is an encouraging novel oral anticoagulant. According to the RELY study, Dabigatran is superior to warfarin in reducing the occurrence of strokes or systemic embolism in non-valvular atrial fibrillation patient and reduces the chances of intracranial hemorrhage. Since the approval of its antidote in 2015, Dabigatran is also the only novel oral anticoagulant with a fast-acting reversing agent. Dabigatran is available in capsule form that can be consumed by the patient twice daily for thromboprophylaxis with a lower risk of intracranial hemorrhage in comparison to warfarin. In an UK-based cost-effectiveness analysis, the use of dabigatran etexylate as a first-line treatment for the prevention of stroke and systemic embolism was found to be cost-effective. Unlike warfarin, dabigatran has a favorable pharmacokinetic profile that produces predictable anticoagulation responses, has few drug-drug and no drug-food interactions. Patients on dabigatran do not require INR monitoring to standardize their dose. Long-term study outcomes of the RELY study over the span of 4.3 years underlined the beneficial outcomes reflecting on both dabigatran 110 and 150 mg doses in prevention of stroke in NVAF patients, which adds to the overall evidence of safety and compliance. All things considered, the implementation of dabigatran, the ultimate goal of therapy in NVAF patients, will revolutionize the approach towards oral anticoagulant therapy. Introducing Afogatran, a brand of Dabigatran by Torrent Pharma, a sure and safer way towards anticoagulation.